Good afternoon, everyone. Welcome to the Center for American Progress. My name is Winnie Stackelberg, and I'm Executive Vice President of External Affairs here at CAP. I want to thank each and every one of you for joining us for a timely discussion about the Zika virus and women's health. In recent months, we have seen Zika's transmission escalate in parts of the developing world and here in the United States. According to the Centers for Disease Control and Prevention, the mosquito-borne virus has infected over 6,000 people in the United States and United States territories, including more than 800 pregnant women. The Pentagon has reported that at least 33 American service members have contracted Zika overseas. And just last week, Florida health authorities reported the first likely cases of mosquito transmission in the continental United States. As CDC Director Frieden recently declared, Zika is now here. These cases are just the beginning, and Congress can no longer ignore this urgent and dangerous public health crisis. The Center for American Progress estimates that more than 2 million pregnant women in the United States are potentially at risk of Zika virus this summer and fall. For pregnant women, the Zika virus can cause and lead to a serious condition at birth known as microcephaly, which can have severe, lifelong effects on children's physical as well as mental development. It can cost anywhere from $1 million to $10 million over a lifespan to care for a child with microcephaly, and there is no vaccine for the condition. Nor is there one for Zika virus, and that's what makes prevention of Zika in the first place so critical. Unexpected health issues like Zika can present tremendous challenges for already disadvantaged communities and sink families deeper into poverty. This is a vicious cycle, as many of these communities live in conditions that can compound Zika transmission, including lack of access to shelter or air conditioning, living or working near standing water, and inadequate health insurance coverage. These families cannot afford to wait any longer for Congress to take action on Zika. The good news is we can prevent Zika transmission. In Zika response efforts, we can help ensure access to contraception, family planning, and maternal health care for women at risk. For families of children born with microcephaly, we can help ensure access to quality pediatric care and social support services. And we can support research and development for a vaccine and adequate testing. But in order to do all of this, we need Congress to abandon political wrangling and allocate adequate emergency funding to combat Zika without harmful restrictions on women's health care. Since President Obama's request in February of $1.9 billion in emergency Zika funding, Congress has played political football with the lives of those at risk for Zika transmission. In fact, the situation has become so dire, the administration has had to shift money from the fight against Ebola because Congress won't approve new funding. Once more, Senate Majority Leader Mitch McConnell, House Appropriations Chairman Hal Rogers, Representative Tom Cole, and other Republican leaders have put partisan politics before the needs of the people they were elected to serve. Here we are in August, the day before the Olympics in Brazil, a place where Zika is responsible for over 4,600 microcephaly cases alone, and we still have no resolution. No dedicated emergency funding. Congress has gone on vacation. And even after they return, Senator McConnell and Republican leaders have promised to make sure Capitol Hill is as inaction-packed as ever. We can't let that happen. The time for denial and delay has long passed, and every day without this funding puts more women and families at risk. Make no mistake, we have the tools to fight Zika. What we lack is a Congress with the political courage to do right by the American people. Today you will hear from a distinguished panel of public health experts and advocates who are fighting to ensure that women and families have access to the services they need in the face of Zika. Their discussion will examine our efforts to combat this crisis and why women's health care must be an integral part of any effective Zika response. But first, we will hear from someone who has been at the front lines of the crisis, Dr. Jewel Mullen. As the Principal Deputy Assistant Secretary for Health at the Department of Health and Human Services, Dr. Mullen has helped coordinate the administration's response to Zika at home and around the globe, and we're thrilled to hear her insights this afternoon. Please join me in welcoming Dr. Jewel Mullen.
Good afternoon. I'd like to thank Nira and the entire CAP team for inviting me to be a part of this important event. And Winnie, thank you for the introduction. I especially appreciate this convening because we're discussing an ever important topic, ensuring access to maternal and reproductive health care at a critical time, the Zika outbreak. A disease characterized by transmission by both mosquitoes and sex that has associated potentially severe birth outcomes. Speaking from my new almost 7-month perch as a federal official, I want to share that as a physician and public health practitioner, I'm speaking to you from both of those heads, knowing that my words are those of a person who will always see herself as a doctor first. People who only know me as someone who works in government ask me, have you ever been a real doctor? But I assure you from the way in which I approach my work that I still am. So know that I mean it and understand when I say that I really appreciate this meeting and your work, because what you do is so much closer to the people, the community, and the patients than I am at this point in my career. For the administration, so much of the work and progress of the past several years has been rooted in the belief, passed down from generation to generation, that we can continue to strive towards equity, and that we can work together to level the playing field for all Americans. That we can give all of our sons and daughters, our families, the opportunity to grow and thrive and succeed is at the heart of that. And if progress is at the foundation of our country's values, we know that health is the bedrock that forms that foundation. You don't have to look far to see the results of that incredible work of the past several years, which now includes having more than 20 million more Americans who for the first time have access to coverage that they need for themselves and their families. Work that's led to a more than 50% decline in the uninsured rate for African Americans and a 27% decline for Latinos. And today, women can no longer be denied coverage for a pre-existing condition like childbirth. But we also know that there's a lot more that we have to do. And even more sometimes when we think about African American and Latino neighbors who are still less likely to have access to health coverage and access to care. Zika challenges us to mobilize around that reality. While women do have improved access, we still have work to do for women's health, knowing that women's health is far more than reproductive health, but that we can't separate the two. Progress on women's health is a comprehensive approach focusing on health and well-being for all women, daughters, sisters, mothers, and grandmothers. 2 months ago at the White House United States of Women Summit, where women from all walks of life came together to say that by working today, we can change tomorrow, I was fortunate to moderate a panel on unplanned pregnancy. And in that conversation were many reminders that I wanted to share briefly for today. Because in that conversation about unplanned pregnancy, we had to remember that what we convey to women, and sometimes I say women and teens because I don't want us to think about one population that we're addressing. We wanted to convey things in a way that really addressed the needs, desires, and understandings of the people that we serve. And that conversation that we had was informed by panelists from New York City and Sierra Leone, among others. So the diversity with which we need to approach that work to achieve equity is key. I've been able to observe in the work that we've been doing on Zika what that means to address maternal and reproductive health with equity in mind, and because of the work I've done in Puerto Rico, to understand that when you're addressing these issues for populations in which the economic conditions can far outweigh the concerns about a disease for which 4 out of 5 people infected have no symptoms, the conversations that require true information and informed decision-making for an individual are needing to be informed by the insights that every one of the panelists here today is going to share. And I want to stress that because one of the things that I understand working at the federal level is that with all of our expertise in science and policy guidance, that's what it is. It's work that we do on behalf of populations. What has to happen with that work is that it has to be translated to be useful for the individual people who need to be able to make personal decisions for themselves, and in this case, around reproductive health. And I know as a physician how much that relies on shared decision-making type conversations with clinicians who understand, who have the information required to be able to help women make those decisions. Some of the work that we've done at HHS in response to Zika have been investing more than $300,000 in emergency funding to our Title X programs in Puerto Rico to expand access to contraception. We've been doing trainings for promotoras de salud to ensure that our work with partners is culturally and linguistically appropriate, and to ensure that our services really reach those who need them most. The Office of Population Affairs last month released a toolkit, Guidance for Providers for Counseling Women. We're also working with states, territories, tribes, and local governments on steps they can take to prevent, detect, and respond to Zika. Alongside that healthcare work, we're sharing advice on the best ways to control mosquitoes, working to improve diagnostic capacity, and to keep the blood supply free of Zika. Winnie already mentioned vaccine development and improving diagnostic testing. And underneath all of that, what might be most important is the hard work that's done every day to improve our communications. An especially important technical and human skill that is so key for everything else that needs to be done to equitably ensure access and enable women to make the decisions that they need for themselves. And we're working with a number of partners to improve women's access to effective contraception. As we do all this, I also understand the limitations of our reach from the federal level, which is why it's so important for us to continue to partner with you and to take your feedback so that we can continue to be better at our efforts. But we do need to work with you to spread the word about Zika, how it's transmitted, how pregnant women, women of childbearing age, and actually everyone can protect themselves. And we need ongoing advocacy for our communities, for us to have the resources that we need to implement not just mosquito prevention efforts and contraception efforts, but sustainable improvements in conditions which, in addition to helping us address Zika, in the long run, when we talk about disparities and equity, can make many more kinds of differences in the lives of people along the way. Thank you for your work. Thank you to the panelists for what you do, and I look forward to our ongoing partnership.
Thanks to Winnie and Dr. Mullen for setting the stage for this important conversation. I'm Jamila Taylor, and I'm a senior fellow with the Center for American Progress. I'll be moderating the panel discussion portion of today's program. We have an impressive group of women's health and rights experts here on the panel today. I'll introduce them briefly, but also encourage you all to access their full bios online. So first, in the beautiful red dress here, we have Anne-Marie Benitez. Anne-Marie serves as Senior Director of Government Relations at the National Latino Institute for Reproductive Health. In that role, she is responsible for the organization's Washington, D.C. office and oversees all government relations and policy advocacy work. Prior to joining the Latina Institute, she worked as Public Policy Director for Planned Parenthood affiliates in California. Next, sitting next to me, we have Claire Coleman. Claire is in her 7th year serving as President and CEO of the National Family Planning and Reproductive Health Association. Before joining NFRA, she served as President and CEO of Planned Parenthood Mid-Hudson Valley in New York and has held a number of positions in the United States House of Representatives, including Chief of Staff and Legislative Director for Appropriations Committee Ranking Member Nita Lowey. At the end here, we have Dr. Christopher Zahn. Dr. Zahn is Vice President of Practice Activities for ACOG, a retired Air Force officer and member of ACOG's Armed Forces District. He received his medical degree from Uniformed Services University and is a specialist in comprehensive obstetrics and gynecology who has been practicing for 29 years. Before joining ACOG, he served as a staff physician in the departments of obstetrics and gynecology and pathology at Walter Reed National Military Medical Center. And last but not least, we have LaTanya Mapfret. LaTanya joined Planned Parenthood Federation of America in 2011. She is the Executive Director of Planned Parenthood Global and Vice President Global. In this role, she sets the course for PPFA's international engagement on all international issues, and prior to joining Planned Parenthood, she worked for the United Nations Children's Fund, as well as the U.S. Agency for International Development. Thank you all again for being here. So the first question I have this afternoon is directed to all of you. And I wanted you all to describe how your organizations are working to address Zika among women. Why don't we start with Claire?
Thank you. The National Family Planning and Reproductive Health Association is a membership association in all 50 states and several of the territories, as well as here in the District of Columbia. We represent nearly 800 institutional providers of family planning and sexual health care nationwide. So that includes 33 state governments, 15% of the nation's federally qualified health centers, and about 80% of Planned Parenthood affiliates, as well as many other private not-for-profit providers of family planning. We're working on Zika response from two approaches. The first is in service delivery. The federal advisories around how we should address people's concern, women and men, in health services has led to a lot of concern and confusion in the field about how to translate guidance, which has moved as new information has come to light, to individual patients who come in with concerns. And so we actually have a team in Texas today meeting with the Title X family planning grantee and their service delivery network to talk about how do you translate the guidance that's coming from the feds and from the local health departments into practice. How do you operationalize preparedness? And then what do providers in local communities need to know today in order to be appropriately responsive to the field? We also work in advocacy and communications, raising the voice and the concerns of this network. We have about 4,100 health center sites around the country, again, in governmental units, in private not-for-profit units, that are all working to interpret this guidance, operationalize it for their local community, do community awareness, make sure they have supplies on hand. And so it's really important for us to also participate in the coalition efforts to call attention both from the administration and the Congress to the pressing need for resources.
Anne-Marie?
National Latina Institute for Reproductive Justice for reproductive health is the is the only national Latina organization that represents 28 million Latinas and their families, and we do it through a reproductive justice lens. And what we do is also twofold. A lot of what we're doing is we have a community mobilization networks and teams in New York, in Florida, in Texas, and in Virginia, which also happen to be a lot of the hot spots in which Zika is taking place. So a lot of our work right now is just working with the community and trying to answer questions and trying to hear what their concerns are and what their needs are, and then relaying that back up to DC, and which is our second part of our work, which is a lot of the advocacy and lifting up a lot of those concerns and addressing them and putting pressure on Congress, for example, to move forward with emergency funds.
Thank you. It's a pleasure to be here, and thank you for having this conversation right now to CAP. It's so important for us at Planned Parenthood because we have the privilege of serving 1 out of 5 women in this country and over 1 million people a year in Latin America and Africa. And so for us, it's incredibly important for us to keep women at the center of this debate around Zika. On a normal day, women who are marginalized and sit in parts of the country, whether that's geographic, and parts of the world where they're not receiving service, they have unmet needs for family planning that we're trying to address. On a normal day, there is, in Latin America in particular, the rate of unsafe abortion is just startling. And was just talking earlier this week with our colleagues at the government about the average 15-year-old in Latin America's initial sexual entrance was through some kind of violence or rape. And so these are women who, when we start, our leaders start saying, why don't we just wait to get pregnant while we figure out how we handle Zika, are the women that we're talking about. They can't do that. And so it's very important for us when we talk about funding and when we talk about policies that women remain at the center and that we take the caution from WHO and CDC that reproductive health has to be a huge part of the response. And so that's where our work centers.
Ron?
Well, again, thanks very much for the opportunity to be here. ACOG has slightly over 50,000 members, obstetricians, gynecologists, and obviously this area is of special interest to us. And interesting, I think it was Dr. Frieden that pointed out in the CDC conference, this is the first time, it's a unique time in history, the first time in history there's actually a mosquito-borne or a vector-borne illness whose primary impact is birth defect, never before seen. So it's an incredible time to be involved in women's health care. Our major goal is primarily clinical. We are in daily, both day and night, and sometimes more than that, contact with the CDC. We work very closely with them, basically to try to implement and spread the message and spread the information that the CDC develops. As I'm sure everybody's aware, these guidelines change quite frequently. We have updated our guidelines probably 6 times just in the last couple of months, and in fact the most recent one came out last night to try to advise. And as also, not surprisingly, when there was very little information known in the very beginning, the guidelines were relatively brief. Well, now there is more known, although clearly we still know far less than what we do know, but the guidelines are much more expanded and therefore challenging to understand and implement. And tying back to your putting in an operation, is the implementation piece, is actually translating those guidelines into practice in the trenches. A patient shows up incredibly anxious, who's been exposed or traveled somewhere, what to do, how to get the testing done, how to interpret the testing, and then advise her on what her risks are, what the prognosis is as best we can, and then how to further manage the pregnancy subsequently. And we work very closely with some of the other women's healthcare organizations, nurse practitioners, midwives, family practice, to, again, anyone involved in women's health, to try to get this messaging out as much as possible. And also, we are involved in advocacy, not only for the funding issue, but also access to health care, reproductive rights, et cetera. Clearly, there's sort of two populations in this. There are the women who are pregnant or planning to become pregnant in their aspects, and then clearly there's the avoiding the pregnancy. And to paraphrase Dr. Frieden, in fact, probably quote in one of his earlier addresses, we don't know how to prevent Zika, but we know how to prevent pregnancy. And we really need to make an effort to do that.
Thank you, Dr. Zahn. Can you walk us through the standards of care in a Zika-related case for obstetricians and gynecologists for pregnant women, particularly when they come in who test positive for Zika?
Well, I should have made more copies, but I do have our most recent practice advisory. But generally for women who, so it varies based on whether a person lives in an endemic area versus has traveled or been exposed. And unfortunately, as of in the last week to week and a half, we now have an endemic area in the mainland. But for people who, so the majority at this point are still going to be those people who travel to an infected area. There are guidelines as far as who should be tested and what type of testing should be done. It's gotten a little bit easier with the most recent guideline, and because there's a division between whether they've been exposed within the first 2 weeks or it's been after 2 weeks but before 12. So that, again, there are guidelines as far as what type of testing should be done in the very early exposure. It's a combination, it's a molecular test called PCR that's done on both a blood and a urine specimen. And depending on the result of that, a follow-on test looking for antibodies is done. They actually sort of flip in people who are exposed beyond 2 weeks, so between 2 and 12 weeks as far as what should be done. And then depending on the result is how they're managed. If a woman tests truly negative and she's asymptomatic, there would be, generally, we would recommend an ultrasound just to make sure there aren't any abnormalities, and if that ultrasound is normal, they're, for the most part, cleared. For patients that test positive, it's obviously a much more intensive surveillance looking for those abnormalities. Going back to, I could keep on going for about another 3 hours, but going back to the issue about far less known than what we know, we do know that roughly 80% of women who are exposed will not develop symptoms, which makes it incredibly challenging. But we also don't know that if a woman gets infected, what her risk of transmission is. So we don't know how many actual babies are going to be infected, and the rates that have been reported range anywhere from 1 to 30%, which is huge. Secondly, we don't know if there are certain women and babies, fetuses, that might be at higher risk of getting affected compared to those who don't. So there might be some underlying immune profiles or other cofactors that may play a role into how that's manifested. For those women that are asymptomatic but still exposed, could they eventually develop disease? The other is the time course. For women, we used to think, based on some of the initial data, that women were at higher risk of having an affected fetus if they were exposed in the first trimester, early in pregnancy. But there's been some subsequent case reports that refute that, and women could be exposed later and a very rapid time course to that fetus developing abnormalities. And personally, I think one of the scariest aspects of this, we know from some basic science research that's been done, that in a lot of infectious disease, the damage that occurs in whatever organ system it is can be related to the infection, but also to the immune response. But we know with some data in Zika that Zika can actually directly attack brain cells, the neurons in the brain. So one of the real fears and a clear unknown that even in an infected woman with a normal baby, the baby doesn't show any signs, no microcephaly, we don't know that that virus is not going to continue to attack the brain cells in the newborn after birth. So we have no idea what those developmental abnormalities may or may not be, what the risks are, what they might be, what the percentage will be. So the importance, one of the most important aspects of everything we're doing is the registry that the CDC has created to follow these children after birth to see what happens to them down the line. Thank you.
For that. And I wanted to shift things a bit and talk about the Title X Family Planning Program, which Claire talked about, which is a huge part of her organization and the work that you all do. You know, as important as the Title X program is in terms of access to family planning for women, it's also been a big topic on the Hill, you know, as well as in the media in terms of, you know, making sure that women have access to family planning through Title X clinics. So can you talk a little bit more about how important Title X is in terms of access to family planning for women?
I'm delighted to, but I would say at first I'd love it to be more central. Neither the President's original request for emergency spending, which of course came about 2 months before CDC confirmed causality, and all of the negotiations that have happened throughout the spring add additional resources for the Title X Family Planning Network. So let's just talk about Title X briefly. It was enacted in 1970 under Richard Nixon, and it is intended to provide a network of direct health services as well as support for poor, low-income, uninsured, or underinsured people across the United States. Today, the network has about 4,100 service sites, as I mentioned, in all 50 states, the territories, and DC. We see about 4 million people. And just to put that into perspective, the Guttmacher Institute estimates that about 20 million just women of reproductive health age need public funding in order to access the contraceptive supplies and services that they need. So we're meeting about the fifth of the need with the resources that Congress allocates on a discretionary basis into the Title X network. It's also important to note that Title X must see patients without regard to their ability to pay. That's true of all Public Health Service Act programs. And we must see people without regard to documentation. So whether or not they can prove citizenship, they must be seen in our networks. So these networks are providing direct contraceptive care, counseling, pregnancy testing, STI screening and treatment, as well as services that support people who want to become pregnant. There's a dual purpose in the law. We must equally support people who want to achieve pregnancy, and that includes basic infertility screening, as well as provide services that help people prevent pregnancy. There is no question that this is the network that is the safety net for the United States. So Title X funded centers are not the place where just people with no insurance go. Folks with insurance walk through our doors every day. Folks with Medicaid insurance come through our doors every day. The Title X funds subsidize the care for people who have no other payer source. But these are health centers as diverse as Parkland Hospital in Dallas, which operates outpatient women's health centers. 33 state governments run their Title X networks in states like Mississippi, Florida, Alabama, North and South Carolina, as well as states like Idaho, Vermont. These are all states where the Title X money goes through the state government and they authorize the network. And so throughout these networks, people are being seen regardless of their ability to pay. What we need in the networks is a drastic infusion of funds to be able to afford, first, the staffing necessary that is trained and ready to do a wide variety of contraceptive counseling and methods, and that's particularly important for long-acting reversible methods of contraception. We need funds to actually buy supply and have it available same day, on site, all across the country, but particularly in the endemic areas. And we need funds to support the community awareness and partnerships we're being asked to produce. So we're being asked by the feds to, for example, connect with WIC programs, because the population that's in WIC is often a population that we see in Title X, to make sure that the folks who are coming in for WIC services can get a sense of what's available in a Title X family planning setting. But there's no funds to do any community education, any partnership development, any awareness. And the last thing I would say, because you're not stopping me yet, is this is a network that has taken $41 million in cuts over the last, since fiscal 2010. So it's a network that has lost enormous capacity. We've lost 1.1 million people out of the networks. We've closed health centers and laid off staff. Jamila was nice enough to note that I came from from providing services. I did 3 rounds of layoffs in 3 years. So you cannot bounce back when the crisis arrives unless you have the money to put the people into place that make these services possible.
So I think, from what you said so brilliantly, I mean, Title X has an important role in communities, and it's already underfunded in terms of the need. But also when you tack on or you think about a public health concern like Zika, you're going to have even more people in need of access to services through Title X clinics. So thank you so much for that. And I want to shift things to Anne-Marie. And Anne-Marie, I'd love for you to talk about the potential impact that Zika could have, particularly on Latina communities. I mean, it was something that Dr. Mullen touched on in her remarks, particularly how communities of color could really experience disproportionate impact when it comes to Zika. So I'd love for you to talk about the Latino community.
Yes, thank you very much. And I'm going to echo a lot of what's been said. We highly rely on Title X clinics to access care because we have a very diverse community. And we have a lot of roadblocks and ability just to access care. So certain things that uniquely impact our community, for example, is just education and culturally competent care education. So in my early remarks, I was saying that we hear from people on the ground. And one of the things that we hear constantly is that there is very little information going right now to the community. And it's hot and cold. Like Zika is really dangerous, or Zika is not going to impact me at all. And there is this thirst and desire to learn more. So there have been requests that we know of from community health workers and promotoras who have the ability to reach out to the community in a very culturally competent way, but they don't have the access to those trainings to learn more about Zika and what they can do. So right now what the community is doing is calling the families in Central America and Latin America and trying to find out what they know so they know what to do here in the United States, particularly in the endemic areas. And then there's there's been cuts to Title X clinics, but we haven't seen the ACA fully realized. So in states where we are particularly focused on, like in Florida and in Texas, Medicaid expansion hasn't happened there. And Medicaid expansion is so important so that folks can have access to care if the clinic is open. So that's, I can keep going on the impacts on how there's limited access, limited education, and limited resources. And that is really impacting our community. And we have a lot to do. Mm-hmm.
Well, thank you for that. And I'll just mention, you mentioned Florida, which has been in the media and in the news over the past couple of days, particularly for new cases of locally acquired transmission of Zika from mosquitoes. And one of the things that I wanted to mention about Florida is the fact that, as Anne-Marie stated, Florida has not expanded Medicaid, leaving lots of people without access to the health services they need. And then also there are over 2 million women there that want access to contraception and contraceptive services that don't have it. So there are some real issues, I think, outside of these new cases around local transmission is the fact that access to family planning and contraception is limited for some women in Florida. So I want to shift things a little bit and talk about the international context a bit. As most of you all know, the Olympics are set to begin in Rio tomorrow. And there's also been some conversation about, whether or not it has been safe to travel to Rio, particularly with the impact of Zika there. And I wanted to pass things over to LaTanya to talk a little bit about Brazil in the context of Zika and how Zika has impacted Brazil, particularly women in the country.
Yeah, no, thank you, Jamila. It's and I'm going to pick up where many of our panelists were coming from. I mean, Zika is going to highlight a public health gaps. I mean, it just and we can talk about that in our country, and we understand where they are and where marginalized women and women who don't have access to health facilities are going to land. But think about that from the aspect of a developing country, even a middle-income country like Brazil, where there is a host of communities, and particularly women You know, and you can women, even Afro-Caribbean women in Brazil and other very special communities in that country and in countries around Latin America who just don't have access on a normal day to family planning, to information about Zika, to doctors even, whereas we know that that's going to be necessary as we seek to address this issue. And so when we think about what women are going to need for Zika and to deal with this, we know that they're going to need more access to contraception, not less. And we look at where the funding is going, where the emphasis, even the communications around mosquitoes is going. I am a little worried that that women in Brazil and other countries in Latin America are not going to be as prepared and ready for this. And we've seen that, I think, and they're most hit, of course, in Brazil than they have been in many other countries. And I think the trend will follow if we're not able to, as you said, operationalize this in those countries. So from the perspective of our partners that we work with in Latin America, it's been very clear that we have to do more of the same kind of work that we've been doing around family planning. We have to do more, a lot more around education to communities, because it's not just in the US. It's, think about women who every day have to deal with the complexities of their lives, having to think about this too, and not even sure, not receiving information, no targeted services or advocacy towards them, and lots of leaders talking about the issue, but not much funding going towards it other than from mosquitoes and research, which most of that is even coming from outside of those countries. And so I think it's crucial for us to think about again, women being the center of this, and when you think about that, how do you get information and services out to these women? How do you increase their access to, in the case of, especially with sexual transmission now becoming, you know, people are hearing it in the news, but they're not quite sure what it means. Is it the same or is it not? You know, giving people the information they need to do for themselves what they need. And I think that has to be from trusted providers like Planned Parenthood here in the US, but also the hundreds of partners that we support in Latin America, because these are the people that women go to anyway. And so we have to make sure they're provided with the resources to be able to continue to have that conversation with their clients and to get that out into the communities through the various community-based programs that we run there.
That's an important point. I think another thing that, you know, sort of comes to mind when we talk particularly about underserved communities is how do we get information to those communities? You know, as Anne-Marie mentioned, you know, in the Latino community, there are people that aren't even getting information and it's not being translated in Spanish. So how do we reach the hard to reach communities, especially when we're sitting here, you know, in our DC bubble talking about Zika and what these communities need, you know, but does the young woman in Southeast DC know about Zika and how she can get information about transmission?
I'll just say from the international perspective, we have to lift up the organizations that are already doing this on other issues. I mean, there are other issues. I mean, I think about Africa with Ebola and malaria. You know, you have the HIV/AIDS epidemic. I mean, you know, there are many community-based organizations that are dealing with similar public health crises. We can't act like they're not there. We can't just say we need to go into trials and look at mosquitoes and some kind of vaccine. We have to lift those organizations up. You know, Planned Parenthood has a host of partners around the world that do this work every day in their communities and very far-reaching communities outside of the major cities of most of the countries in Latin America. And we have to support organizations like UNFPA, again, that's there every day in doing this work and now have a particular role, but they're getting less funding than ever before. We have to think about international family planning, again, that's getting less money than ever before. So Zika now is here, and we're having to address these issues, but we're not thinking about how to support and strengthen those structures and partners that are already in place, and we need to do that.
And those
seriously.
are the experts
Those
in
are the
terms
experts.
of figuring out how to
And
reach those communities.
that's who the communities go to. That's who they trust.
Right,
you know?
absolutely.
Right, and I would lift up what was said, what you had said earlier, that Zika is an example of just highlights where we have gaps in care and gaps of access and gaps of services. So we know what to do to prevent an unintended pregnancy. And we should dedicate those resources and build upon them instead of cutting them, which is what we're seeing instead happening. So I think is looking at the infrastructure, building on the infrastructure, and going back to what you have already said, which is there are a lot of community-based organizations, including us, who are already on the ground, who are already trusted folks for people to turn to. We just need the resources to give them the information. And that, I think, is also a key element to what we're doing and working on.
Right, and so you mentioned resources, and we've all talked about you know, the lack of moving forward in terms of funding from Congress. The request was made several months ago by the president, $1.9 billion to address Zika transmission in the U.S. and abroad. So I just ask you all, you know, what do we do while we, you know, are essentially in a situation where we have to wait for Congress to appropriate the funding we need to address this issue?
Well, we can't wait. And so, you know, certainly there's been some effort from administrative agencies to move money that was available. So Puerto Rico, for example, got $300,000 in emergency money in April. That money went directly from the Title X system into the Title X grantees in Puerto Rico. That's very important to underwrite their efforts to, the rate of unintended pregnancy in Puerto Rico is criminally high, and women do not have access to methods at a much greater rate than we see in mainland U.S. So $300,000 is a drop in the bucket, but for those two systems in Puerto Rico, they were able to put that money right to use. There's also been a lot of emphasis on training, which I think is not unimportant. You know, that's really getting the pipeline put together. And the notion here is that there are lots of places in the country, and this is particularly true in governmental health systems, where the local health department is family planning on Monday, infectious disease on Tuesday, the school nurse on Wednesday, back in the local health department on Thursday, because the local health department's doing everything, right? So these are not networks that are offering 5-day, 6-day, 7-day-a-week access to contraception. So when you wind up in a crisis in a governmental family planning system, sometimes delay is just because Monday's family planning day, and we don't do family planning until next Monday. So this notion of trying to be ready every day for a patient who may come through the door and say, I have been traveling, I have been exposed, I'm worried, what can I do? I'm going to be traveling, I'm in an endemic area. So that we can meet their needs immediately, that's what we've been doing without one thin dime. I really would love Congress to stop the shell game around existing resources. There is absolutely no way that we can fill the gap in public health in the U.S. without coming to a reckoning about how much we've destroyed the public health infrastructure in the United States. And it's not just true for family planning, it's also true for STDs. You know, now we understand Zika is a sexually transmitted infection. Well, we've lost 30% of the capacity in the sexually transmitted disease system in this country due to funding cuts that have happened over the last 6 years. So this is not a battle-ready public health infrastructure. And it's really unfortunate in this country that it takes crisis to draw attention. I think in the past, this country's been able to pull it together in crisis. And this is a place where we have stopped dead. We are not making progress in the face of a crisis.
The other thing to highlight too in this is it's more than just having providers and having supplies to provide contraception. I mean, that's based on the assumption that 100% of women will want it. We clearly have cultural aspects and that sort of thing we need to consider. And this is to highlight Puerto Rico. As you said, the unplanned pregnancy rate is incredibly high, but some of that is cultural, that they just don't believe in contraception, and some of it's certainly religious background, and we face some of those same issues in the mainland U.S. So it's really critical that we get the importance of the education out, that this is a public health crisis, that contraception is not just a pregnancy prevention because of having sex, it's pregnancy prevention because of this incredible illness that can affect the unborn, or that can affect the fetus. So I think the education piece is not only, I mean, certainly looking from our perspective, we've got to educate our providers to get the word out and talk to their patients and work in the local communities, but it's also, we've got to educate the patients as to what the risk really is and to try to address some of these cultural and various, in some cases, unfortunately, myths and misperceptions about contraception and the dangers of contraception. So we've got another battle to fight as well.
But it also comes home that notion of all the institutional racism in our society. And so when we're talking about building trust, I think what LaTanya and Anne-Marie have talked about, people who are in the community, whether they are an institution in the community providing healthcare or they are a community resource, this is a place where people go to trust. And it's not going to be earned in the crisis. And there's lots of concern in Puerto Rico that they are being experimented on when it comes to Zika prevention. And I think if we aren't honest about that, and we don't,
they have been.
Correct. And there are lots of good reasons. So if you're not honest about that and you don't go into that conversation saying we recognize that there has to be a reckoning, then there's no way that we're going to be able to engage patients appropriately, to make the decisions based on their risk that are right for them, that are sensitive to their needs, and in the end respect their autonomy.
And think about it also, I mean, I think to your point about education, I mean, think about women who are thinking about all of these things on unwanted pregnancies. Yeah. Think about those that want to. I mean, it's impossible to believe that every woman, whether in Puerto Rico or anywhere else, is going to say, okay, well, I'll take off for a year when it's time for them to get pregnant, when they want to have a baby. We have to get information, and we have to be able to provide services and medical facilities for women who do want to have babies, even in an endemic area with Zika. So, I mean, I think we're just, highlighting together that I think the public health infrastructure and the resources that go into this under Zika has to be thought about serious. There's no time for politics in this. It is something that we need to do soon. It should have been done before Congress left.
And to build on the public health infrastructure, like we're saying, education, so sex education is a huge component of that, but also recognizing that not everybody has the ability to access care because there's policies in place.
Right.
For example, undocumented individuals can't purchase into Obamacare, so and they can't purchase it along with subsidies help, so they can't have affordable health care. So we have to look at all the components to make it battle ready. And then I would be remiss to say, in terms of contraception use within Latinos, a lot of it is just not being able to get to clinic. Like Texas implemented HB2 partially, and a lot of those clinics shut down. So to just drive to a clinic is far away, and you have to take time off of work if you have the job to be able to do it. So access to contraception is a huge component of why Latinos don't have or don't have the ability to access care. And I would argue that what we've known is that we've heard at least 96% of Latinas who are Catholic say they use contraception. So we need to debunk these myths also about our community, about why or why not we're using contraception. And that is all part of helping build this public health infrastructure so that we can respond to emergencies in a timely way like Zika.
And I'll just also add, and we're definitely going to get to questions from the audience after this last point, that, to build upon Anne-Marie's point about restrictions or policies that keep folks from accessing health services. In a lot of the states that, the CDC has estimated, could see an uptick in Zika-related cases, those are also states that have highly restrictive abortion laws. And, access to safe abortion should be a part of the full spectrum of reproductive health care for women in this situation. So with that said, we're going to pass things over to the audience for questions. The floor is open. Okay. Yeah, go ahead. Oh, they're coming.
Hi, Jill Gay, What Works Association. My question is around the last point that Jamila just raised about access to safe abortion, particularly if Zika can't be diagnosed until the 4th month. And in so many states, access is only for the first trimester. But would you comment on that and also the issue globally?
Yeah, I could quickly talk about, the fight for safe abortion continues. And what happens here is that we've been talking about these issues for a long time. So whether it's Zika or whether it's some other kind of issue that a woman has to have when she's making these decisions with her doctor, it is very clear that we have to ensure that there's an availability of safe abortion for every woman and access to it. and not her jumping through hurdles. It's especially true now. I mean, we could talk about Texas. I mean, that might be a good example where, our colleague just talked about now there's no clinics. You've got Zika, and, and there probably very soon will be a situation where it's endemic there as well. What does a woman do? And so I go back to what Planned Parenthood has said for a very long time. We have to be, in the cases where a safe abortion is legal, we have to be able to provide access to the most marginalized women who can't get it. And overseas, I think it's exactly the same thing, but we actually probably have a bigger conversation because in many of those countries, if not most, it's illegal to have an abortion, period. And then it has to be something, it has to be a serious situation where the country does allow it in the circumstances of health. And is Zika one of those? And so, you have to start getting into the policy question of which, many of our partners are starting to look at now. There's another.
I would just add that all the state policies that are focusing and attacking on abortion, what's happening is limiting the full spectrum of comprehensive reproductive health care, but also impacting access to care. So you're closing down clinics like we've seen in Texas. Florida just passed a bill which hasn't been implemented yet, but it would defund Planned Parenthood. And that is a huge concern of us. So you see the trickle impact and how it impacts people's ability to have full autonomy of their bodies and therefore can't protect themselves when things like this happen. So we see an onslaught of this, and NRLH is part of many of us working on the forefront to try to fight these state-level laws that are really negatively impacting access to care.
Go here. And then the one in the back next. Oh, okay.
Hi there. I feel very concerned for the young women in Texas and their access to abortion. My question, I believe, would be to you, sir, as a physician. Abortion is a medical procedure, and I would imagine that between a psychiatrist and an obstetrician, if a woman's fetus is claimed to have, if evidence indicates microcephaly, certainly an abortion would be medically necessary, if not for the emotional health of the family, etc. Do you follow? It's a difficult question because it's a difficult predicament. Thank you for reading between my. Thank you.
I very much understand, and as has been said, we certainly support, as an organization as well as our providers, for the full range of reproductive care that's available, which obviously includes abortion. Part of the challenge, as also touched on, is when a woman manifests these findings by ultrasound, it may be very late in pregnancy, and there are clearly state laws that impact the upper limit of when they can be done. So that's a separate problem. But your point, I don't think I would use the term medically necessary. The determination, it should be an option. There should be an informed and shared decision-making process between the patient and their provider, but it's the patient that ultimately makes that decision. I don't think there would be any clinician that would say it's medically necessary that you terminate this pregnancy for whatever reason. It could be a genetic abnormality, a chromosomal abnormality, some other congenital defect, even a lethal defect after birth. Anencephaly, for example, use that. We don't tell patients your baby's anencephalic, they're going to die after they're born, you should abort now. That is strictly a patient's decision when it gets to that point. There are women who want to know so they can prepare to take care of a patient or an infected infant. There are women who choose to terminate. It's the patient's choice after an fully informed decision-making process, and time for her to process that and talk with family and her support system to ultimately make that decision.
We have time for one more question back here. Thank you, Dr. Zahn.
Hi, I'm Kate Ryan with NARAL Pro-Choice America. Thank you so much. One of the questions I wanted to ask is about sort of making sure women have the information they need. Obviously, we're strongly supportive of women having access to contraception and to Title X clinics. But my question is actually more of a technical one. The CDC has been putting out guidelines for kind of women who are exposed and or are testing positive for Zika when they might get information about potential problems for the fetus. And, initially they had been saying 28 to 30 weeks is when they might be able to detect. Then there's some information it might be sooner, 18 to 20 weeks. And I was wondering if you could comment on the state of the research about when women are sort of, throughout the course of their pregnancy, when women are getting the information they need. And if, frankly, if providers are being, is it a training issue, kind of how early it is detected or not, or is it really just dependent on an individual pregnancy?
Dr.
No,
for
sure.
you.
Well, the unfortunate thing is this goes back to what I said earlier. There's far more unknown than known regarding, and so unfortunately there is no answer to your question. Even in those patients, the little bit of data that's out there that have been presumably infected during the first trimester, when that's manifested in the fetus is a wide range in the few reports. So there may be those that manifest very early on. There's one case report where, and I forget the exact timing, but I believe it was roughly around 19 weeks, the ultrasound was normal, and 3 weeks later the fetus was severely affected. So it could be a very rapid development, it could be delayed, or they may not do anything at all. So we really don't have the ability to, unfortunately, to counsel a woman that even if she tests positive, to say, first of all, your likelihood of developing, your fetus developing microcephaly is this, and secondly, even if that were to happen, how long it might take to develop. So it's unfortunately a very, very difficult counseling situation.
Also think about the access to care then, right? So that's a stage of pregnancy, for the many of us who have gone through this, where you're not getting regular ultrasounds. They're not indicated at that stage in pregnancy. So you're talking about having to access resources much more often. Now that would be difficult even in an insurance context, because insurance has limits on how often and sort of what the expectations are in a pregnancy progressing normally. But in these situations, we're going to be scrambling to figure out, how do you get access? How does it get paid for, et cetera? So I think, I'm very qualified to speak to that part of this consideration. So, regardless of how much money you have or how many supports you have, you're going to be in this situation where no one can really tell you how often testing is going to be required. And I think that's also something we have to bear in mind as we get to this question of when are the resources coming to support women in all situations.
And I mean internationally, where women probably go through their pregnancy without
nothing,
one.
not a single one. Yeah.
And I'll just say too, even in the context of Florida, that there are new guidelines asking women to get tested for Zika more often throughout their pregnancies, and I know that insurance coverage has also been an issue even in that context. Yeah. So we'll continue to talk about this issue. And I just want to thank everyone for being here today. This was such a great panel and conversation. I also want to thank Dr. Mullen from HHS and Winnie Stackelberg, who gave opening remarks for CAP. CAP will continue to work on this issue and think of new analysis, especially around how Zika is going to disproportionately impact low-income communities and communities of color. So thank you all for being here.